Basheeruddin. I'm a surgical oncologist. I would like to introduce my esteemed panelists, Dr. Shabber Zaveri, Senior Consultant Surgical Oncologist and Head of Surgical Oncology, Dr. Suraj Manjunath, and Dr. Hemanth GL. So these are my panelists for today. All of us are surgical oncologists. So the topic of discussion today is robotic surgery in surgical oncology and also the recent advances in surgical oncology. So let us come to what is robotic surgery. Robotic surgery basically means the surgeon controls a device which is a robot in order to operate on a particular patient. There is a misconception around the robotic surgery thinking that the robot actually performs the surgery. It is not that. Basically, a surgeon sits on a console and with the help of master controls, an extension of the surgical hand happens and the surgeon controls the instruments on the patient's body and operates fine precision surgery happens. So let us start the discussion. My first question to Dr. Shabber Zaveri is what is robotic surgery and how is it different from the traditional surgery?
Traditional surgery has always been an open surgery where large incisions are made to access the area of surgery. And there were a few disadvantages with the open surgery. So to counter that, the first technology which came was the laparoscopic surgery to minimize the incisions and to reduce pain. Following that, the robotic technology is now in vogue and it is there since the last about 10 to 12 years. This technology uses a special way in which surgery is done for patients, and it generally has a three-dimensional camera which makes the surgeon feel that he is actually standing next to the patient and looking inside the abdomen or thorax and doing a surgery. It gives you a depth of perception, a perception of depth to see actually how deep the structures are and how deep you have to operate. It also has specialized instruments to control the movements. So these movements in a surgeon's hands are the wrist and his fingers. The same movements are translated into the patient using the specialized instruments and with the wrist and the fingertip movements. It also decreases the tremor. So as surgeons grow old, they start having tremors. So this particular technology has something called as a tremor filtration, which does not get transmitted into the patient, and the stability of the surgery is much more greater. So these are the technologies which are incorporated to make robotic surgery far superior to that of laparoscopy.
Okay, now over to Dr. Suraj. What are the advantages of robotic surgery when compared to the traditional open versus laparoscopic surgery? If you could tell in brief.
As my colleague Dr. Shabber Zaveri mentioned, traditionally it used to be an open surgery where we used to make big cuts, big openings to access abdomen, and even then, because the surgeon used to stand about a couple of feet away and look inside, access to remote corners and dark recesses and all used to be difficult, and the hands and the instruments could not go into deep depths. The next step was availability of laparoscopy, minimal access surgery, which was superior in that aspect, both access and vision and going into corners and lighting. However, there were certain disadvantages, that the limited range of motion and the camera holder being a human person, that they had to hold and stand for a really long time and focus, and both the assistant and the surgeon had to work together. And ultimately, the range of motion of the laparoscopic instruments were limited. Now, with the advent of robotic technology, a lot of these challenges have been overcome. In the sense, the access inside the patient, the body cavity of the patient, whether it is abdomen or chest or other places, can be done through a very fine, minute incisions. Access can be deep inside. The camera system is three-dimensional, so the perception of depth is also very good. And even the instruments have got multiple ranges of motion, resembling the human wrist. Whereas laparoscopy used to be straight, here there are multiple range of motion and we can come from any different angles. And also the third arm as well as the camera is controlled by the robotic surgeon himself. So these are the potential advantages. And also the filtration of tremor, stability of the instruments, and a lot of inbuilt safety mechanisms that have been built into the robotic technology. These are all aspects which are far superior to the traditionally available open as well as laparoscopic technologies.
And Dr. Hemanth, I would like to ask you, what are the benefits of robotic surgery? You can tell in terms of patient comfort and the surgeon's comfort, both.
So, as already alluded to by Dr. Zaveri and Dr. Suraj, so robotic technology has many advantages over open surgery as well as laparoscopy. One and foremost among them, I would say, is the long surgeries which were done with laparoscopy resulted in a lot of fatigue to the surgeon, and because of which a lot of errors in surgery could occur. This can be minimized here. The element of fatigue is almost nil because it's the robotic arms which are doing the work of the surgery, being controlled by the surgeon sitting away at a console. So he can take a break if he has a fatigue, which is not generally possible in laparoscopic surgery and also the traditional open surgery. So that could translate into smaller cuts, faster healing, lesser blood loss. The blood loss is less because you're getting a good vision in depths. You'll be able to see even the tiniest of blood vessels magnified many times with a three-dimensional view. And all this translates into faster patient recovery. Patient will be able to go home earlier. So sometimes we even ambulate the patient or make the patient walk around after a surgery of about 5 to 6 hours, and that day evening itself, the next day morning, she will be walking around the hospital and probably being discharged on the third day of surgery. All these are relatively new in terms of the discharge, patient comfort. The surgeon also has many advantages like we already mentioned. So these are some of the advantages to the surgeon as well as to the patient when it comes to robotic surgery.
To summarize the benefits of robotic surgery, as I've got from all our panelists, is the most important benefit here is the camera is under the control of the surgeon. Instead of the traditional laparoscopic surgery, where we were dependent on an assistant to show us that difficult area, and we would have to tell them to show that particular area. Here, the surgeon himself takes control of the camera. He can zoom in or zoom out, take the camera in whatever direction he wants to take. That is the first benefit which I could derive. The second thing is the surgeon is comfortably seated and he gets a three-dimensional vision of whatever he is operating, along with that perception of exact depth, which is again not possible with a traditional laparoscopy, because there it is a two-dimensional, though we have the newer technology in that also. But we'll have to wear additional wearables on in order to get that three-dimensional vision. And again, the third arm is a very important additional tool in our robotic armamentarium, in the sense it does the work of a retractor and an assistant surgeon, wherein the third arm can retract and can pull, can do whatever you have to do, and it will stay there. So these are the advantages which I could get. So now let's go to the second part. Are there only advantages? Is there any disadvantage to robotic surgery, sir?
Yes, so there are a couple of disadvantages to robotic surgery. Since this is a new technology, it comes with a cost. And not all centers in India are equipped with a robot. So accessibility to robotic care or robotic surgery is limited in India as of now. But there are a lot of hospitals in the major cities which do have a robot, and therefore it is mostly the people staying in the city who can get access to the robot, albeit it comes with a cost. So when you compare the cost between open laparoscopic and robotic surgery, the cost is, I think, generally more with the robotic surgery, and I think that is the price you pay for technology. So that is one particular disadvantage of a robotic thing. Second is that surgeons have to be trained for robotic surgery. It's not that if you are an open surgeon, the hospital gets a robot and you start using a robot immediately and start doing surgery. There is a period of learning for a robotic surgery. And like all other technologies, there is always a learning curve when it comes to any surgery. So I would say that the learning curve is least with the robotic surgery when you compare it with the laparoscopic surgery. And the third disadvantage of a robotic surgery is the perception of tissues. Is in an open surgery, the surgeon can feel the tissues. But in a laparoscopy and a robotic surgery, the feel of tissues isn't there. So that is called haptics. So when you don't feel the tissues, whether the tissue feels normal or whether the tissue feels diseased, sometimes you enter into a tissue which you think is normal, but it could be diseased. So that is the third and the biggest disadvantage of a robotic technology at present.
Coming to Dr. Suraj, can we get a few differences between laparoscopy versus robotic surgery? Could you elaborate on that?
So both laparoscopic surgery and robotic come under the category of minimal invasive surgery, because the principle that we don't open the body widely, and we rather access body cavities through small incisions, use a camera system to look inside, and use instruments passed through ports, that is the tiny tunnels, metal tunnels, into the abdomen and or the chest or any other organ, and do the operation. However, laparoscopic surgery is more manual, in the sense both the surgeon has two hands, so he operates using both the hands, and there is one camera which is passed by the assistant surgeon who shows what the surgeon is operating. In addition, we may require one or two more personnel to pass other instruments and retract, that is, hold the tissues away from the site of operation, or pull or push and all that. So it's a more manual. In addition, laparoscopic surgery has limited range of motion. That means they are straight instruments, laparoscopic surgeries. At the tip of these straight instruments are instruments which either open and close. They may be curved or straight or cut scissors, but they are basically open and close. They don't have the manual dexterity of the human hand or human wrist or fingers. In robotic surgery, whereas the principles of access and visualization are similar. But as we have been telling, one is the vision is three-dimensional, just like an open surgery. In laparoscopy, it's 2D, although technologies are there to overcome that. However, robotic is inbuilt with a three-dimensional system. And robotic compared to laparoscopy, the main thing is the degrees of movement. What we say that it's like an endo wrist. The hand and the fingers can be replicated. In fact, sometimes more than the hand, because the hand can only turn this much, whereas the robotic can turn completely 360 degrees. So the dexterity of movement with the robotic is much higher than compared to laparoscopic surgery.
So, Dr. Hemanth, I would want you to tell me where we can use the robotic technology in order to perform. What surgeries would you advocate the robotic technology?
So, robotic technology can be used in various cancer surgeries. It is very useful when it comes to accessing narrow places in the abdomen specifically, and one of that is the pelvis, one of the narrowest parts of the body. So like we have been telling that access to this area is very difficult in open surgery, yes, in laparoscopy a little better, but best done in robotic surgery. So pelvic surgeries, to name a few, it would be rectal cancer surgery, in which we can do precise work of surgery, and uterine uterus surgeries, removal of the uterus, hysterectomies when it comes to malignancies of the uterus. And another place, especially which is used quite commonly, very useful when compared to the laparoscope, would be the thorax. It is very useful for esophageal surgery, in which it's a complex surgery, requires a great degree of vision, three-dimensional vision, and that is definitely useful for esophagus cancer surgeries. And for other structures in the thorax, for example, the mediastinum, removal of excision of thymomas surgery, and in the abdomen it can again be used for colon surgeries, right hemicolectomy, left hemicolectomy, cancer of the bladder, which is another organ in the pelvis, it's very commonly used. And even in the upper abdomen, it is being increasingly used nowadays, mostly because of the advantages which I've already mentioned. Gastric cancer surgery, it's even being used for one of the most complex surgeries known in the cancer field, which is known as the Whipple surgery. It's also being done robotically now with very good results.
So one thing which I would like to mention about the disadvantages of a robotic surgery, which I didn't mention last time, was that robotic surgery cannot be used for all cancer surgeries. So if the patient has undergone, let us say, multiple explorations of the abdomen by an open technique, then in those patients, using a robot or a laparoscope is very, very difficult and challenging, and it may damage organs. So we generally would not advise robotic surgeries or laparoscopic surgeries for those patients who have had multiple abdominal surgeries previously. So that is one place where we would discourage the use of robots.
So, as rightly told by all the panelists, the robotic surgery, the principal advantage is movement of the tips. That is, the laparoscopic instrument has a straight tip, and the straight tip instrument, for it to be maneuvered, the operating surgeon has to take up difficult positions in order to reach a certain place, or in order to reach a particular angle. That problem is solved very well by the robotic instrument, wherein if a human hand has 5 ranges of movement, the robotic instrument tips have 7 degrees of movement. So that is an advantage. Doing fine surgical work at critical areas, like if we are operating in the thorax, operating around the superior pulmonary artery or pulmonary vein, which are very critical structures, wherein one injury to the vessel can be devastating, can be life-threatening to the patient. So, in order to do the manipulations with the 10x degree of magnification and additional degrees of moments, we can perform these difficult surgeries very easily. So this is the most important advantage, is what I could get out of it. And as you all rightly told, robotic surgery is not the answer for all the surgeries. It has to be chosen wisely. But when you choose it wisely, it gives tremendous benefit to the patients, both in terms of recovery and most importantly, very minimal pain. Because in laparoscopic surgeries, the trocar tends to move a lot, and there is some pain at the trocar site. Whereas in the robotic surgery, since the movement happens at the tip, there is hardly any trocar movement, and the pain is very less when compared to the laparoscopic surgery. So let me ask Dr. Zaveri, how is the recovery typically from a robotic surgery in your experience?
So the recovery from a robotic surgery is generally faster than that of an open surgery, principally because you are causing less pain to the patient through small incisions which are basically used in robotic surgery. Whereas incisions which are used for open surgery are usually larger and they are more painful. So once the patient doesn't experience post-operative pain, they are encouraged to be mobile, start walking. And in certain areas of the body, we encourage them to start, oral feeding the same evening. And so this is one of the greatest benefits to the patient. Also, it translates into a shorter stay for these patients in the hospital. So typically, when we do robotic gynec oncology cases like hysterectomy for patients, and in open surgery, patients will stay for 5 to 7 days in the hospital. Whereas in the robotic procedures, we discharge the patients generally on the 2nd or 3rd post-operative day. So thereby it reduces the stay in the hospital, and it also cuts down the cost of the hospital stay. So these are the great advantages to the patients in terms of robotic technology.
Dr. Suraj, there is a myth that in the robotic surgery, the robot performs the surgery. Would you like to elaborate on that? How is it different?
Now, see, the robot is not independent. It's not intelligent or sentient. It is a tool. It is a technology. The platform is robotic. However, ultimately the surgeon who is performing the procedure. The robot is only the tool. It's like someone driving a car. Ultimately, it's not the car which does it. It's the skill and expertise and the experience of the surgeon doing the thing. However, the technology is very superior. It's advanced technology. That is something we have to understand. And we have to utilize it in a way that it helps our patients the best. But there is no doubt that there is not an independent entity and it cannot do anything on its own.
Okay, Dr. Hemanth, what are the uses of robotic surgery in terms of sentinel node biopsy? If I may ask, in particular to carcinoma endometrium, what is your take on this?
So, sentinel lymph node biopsy means that it is the first draining lymph node which might be involved by a cancer. So, if the theory behind that is that if that lymph node is not involved, the rest of the lymph node basin is not involved. So, this is not something new, but it has been in vogue for a while. But how the robot plays a role in this, particularly in endometrium cancer, is that the robot has something known as a firefly technology inbuilt in it, which helps us to identify a lymph node. The procedure would be to give a particular dye called as an indocyanine green, which is instilled in the cervix just before the surgery. So using this firefly technology, you will be able to see the green color going into the first lymph node. So the entire lymphatic draining into the lymph node can be clearly visualized with this inbuilt technology in the robot, which is known as a firefly technology. So this helps to accurately identify the node and remove only that specific node which is stained that green color and send it for what is known as a frozen section during the surgery. The entire thing is done during the surgery. So we get the frozen section reports in about 15-20 minutes, and if that turns out to be negative, so that would be the end of the procedure in terms of the lymphadenectomy. So prior to this, we used to have to remove the entire lymph nodal basin, which would lead to significant morbidity in terms of longer hospital stay, a few surgical complications, and lymphedema, all those things, which can be totally eliminated with this technology which is inbuilt in the robot known as a firefly technology, which helps us to identify the sentinel lymph node easily.
So yeah, as Dr. Hemanth just told, this is one of the major benefits of having robotic surgery, wherein the firefly technology is inbuilt within the camera system. There is no additional tool which is required. Just by the push of a button on the console itself, we can access the firefly technology, wherein as whatever dye is given, the draining lymph node or the lymphatic is stained green, which lights up like a firefly lights up. So that is the name which is given to the technology, which is the firefly technology. That particular lymph node is taken out, and while the patient is yet on the table, we send that lymph node to the pathology lab for frozen section. And once the report comes out negative, we avoid the extensive surgery which is called as the lymphadenectomy, and avoid potential lymphedema, which is basically thickening of the limb and thickening of the skin of the limb, which leads to first thing is cosmetic disfigurement. The second thing is even in the movements and the ambulation in the post-operative period, in the long term, it is a difficult challenge to address. So when we know that the lymph node is negative, the chances of having lymph nodal metastasis to our other lymph nodes is very minimal. So this technology avoids us to do extensive surgeries where it is not indicated. So when the surgery is limited, the patient recovers faster, as Dr. Shabber Zaveri has already told. We've even discharged our patients on the second post-operative day itself, wherein the patient gets admitted a day prior. We operate on the day of surgery. We operate. Immediate next day, the patient is able to walk home. This wouldn't have been possible in a traditional surgery. Say even in esophagus surgery, where previously we would have to make a big incision, big thoracotomy, the patient would have a lot of pain. Nowadays, with the advent of robotic surgery, we just make a few puncture wounds basically and access the thorax, do the surgery. The very next day you go and see the patient, he is up and about, sitting and doing all his routine activities, which wouldn't have been possible in the olden days. So these are the advantages. So now we've come to the end of robotic surgeries. Apart from the robotic surgeries, let's discuss a few recent advances. Now, one of the things which we need in an oncology setup is a facility for frozen section. So what is the role of frozen section and how is it useful in oncology practice? And frozen section, as you all know, is not available at all the centers, since we have a comprehensive cancer unit, And ours is a major cancer center which has been performing cancer surgeries. Dr. Shabber Zaveri has been here for the last more than 2 decades. We have one of the high volume centers, so about frozen section.
So frozen section is also known as intraoperative consultation with the pathologist, between the surgeon and the pathologist. And it is essentially equipment which the pathologists have to tell us if a tissue which we send to them has cancer in that or not. Now, in previous days, when surgeries were done, especially for patients with breast cancer, the norm was to remove the breast lump or the breast itself and to remove all the lymph nodes in the armpit, what we used to call as an axillary lymph node dissection. But after availability of this sentinel lymph node technology and the use of intraoperative frozen section, a lot of these patients who tested negative for disease in the lymph nodes were, we avoided doing an axillary dissection in those patients and thereby, reduce the chances of these long-term lymphodemas and paresthesias in the arm by use of this technology. The other place where a frozen section is very important is that if you are operating on a tissue and you don't know whether this is a cancerous tissue or a non-cancerous tissue, during surgery, you have to take the help of your pathologist. Excise the tissue, send it for a frozen section. If the pathologist tells you that this is not a cancer, then your surgery is limited. If the pathologist tells that this is a cancer, then you have to go and do an extensive cancer surgery, whatever is apt for the patient at that point of time, thereby preventing another trip to the operation theatre, increasing the cost of surgery, increasing another, avoiding another surgery and the pain associated with that. So these are the uses of frozen section, which is widely used in our hospital.
And coming to the uses of indocyanine green, the technology of ICG, how do you think it is useful in oncology practice?
So, indocyanine green has numerous applications. Basically, it is a dye, it's a green colored dye, and there is a special instrument which picks it up. It's a combination of the dye and the instrument. So, one of its uses which we commonly use here is in the sentinel node, which we have been talking about. Sentinel node earlier used to be done using a simple naked blue dye, and we used to look at the color. Then there are techniques which use the radioactivity of certain materials which we inject into the patient and then use a radioactive probe to detect that. Now this indocyanine green has advantages of not using radioactivity and using the inherent property of the dye itself, we can use a probe to pick it up. So one aspect of its use is in sentinel node biopsy, widely used for breast cancer, certain skin cancers, endometrium, that is the uterine cancers, and even certain gastrointestinal cancers and head and neck, that is oral cancer. So this is a technology which is much user friendly for the surgeon to use and benefits for the patient also. In addition, the use of ICG, that is indocyanine green, is also to see whether tissues have good blood supply, that is tissue perfusion with blood. So after certain surgeries, suppose for example if we are removing a portion of the large intestine, that is the colon, after removing the portion, when we want to join back the remaining ends, we want to make sure that the blood supply to the remaining colon is good. So ultimately, because that is what will impact the healing. If you are not certain and we still go ahead and join, later on in the post-operative period, the joint may not hold, it may give way. That's called an anastomotic leak. By using indocyanine green during the surgery, that is intraoperatively, allowing the dye to go and confirming that the blood supply is adequate, the risks of post-operative anastomotic leak are significantly reduced by using this technology.
Yeah, as you rightly mentioned, this is again used in even robotic surgery. The indocyanine green is the dye which is injected, and with the help of Firefly technology, just before we do our anastomosis, say in low rectal cancer, which is one of the most common indications to perform robotic surgery, which is robotic low anterior resection or ultra low anterior resection. At the end of the surgery, once we have done all the dissection, we make sure that the vascularity of the bowel, which is to be joined to the remnant portion of the bowel, is very good. in order to avoid post-operative complications. The most important post-operative complication here is anastomotic leak, which can even lead to again redo surgery or even lead to sepsis and death of the patient. So in order to avoid this potentially devastating complication, we use the indocyanine green to check whether the bowel is perfused, with whether the vascularity to the remaining bowel is adequate, and only then we transect, that is cut that portion of the bowel and anastomose. And what are the artificial intelligence used in robotic surgery, if you could mention?
Yeah, so in robotic surgery, because like we rightly discussed already, the tissue feedback is an issue, as in the surgeon does not get a feel of the tissues because he is operating with the help of instruments. So you cannot feel the tissue, so you don't exactly know how thick a tissue is. So this is one the limitations as we already discussed, and to overcome that, there is some amount of AI which is incorporated into the robot, that's artificial intelligence, and one among that is the use of a specific kind of a stapler which senses the thickness. Stapler is an instrument which is used to cut a particular part of the intestine, small intestine, large intestine, so each of which has different kind of thicknesses. So this is incorporated into the robot, in which tells us whether the tissue thickness, when you're using a stapler, is that particular stapler adequate to seal that bowel or the small or large intestine which you intend to close with the help of a stapler. So this is a big advantage, and this is one of the ways in which we are trying to overcome the limitations of the robot, in that we don't have a tactile feedback. So this is a newer incorporation into the robot with artificial intelligence in it.
Let's move on to another topic apart from robotic surgery. So when it comes to particular cancer, which is called as ovarian cancer or primary peritoneal cancer. Ovarian cancer is the third most common cancer found in Indian women, but surprisingly it is the most common cause of death. That is, it is the leading cause of death in women due to cancers. The reason for this being the ovarian cancers are tend to present to the doctor at a later stage. The patients with ovarian cancer usually come to the doctor only when there is significant abdominal distension. Since it being a pelvic organ, the manifestations of the disease happen pretty late. Even in the developed countries, patients present in stage 1 in only about 10 to 15% of the population tends to present in stage 1. When the patient presents in stage 1, the chances of cure are very high, above 90%. But what happens traditionally is the patients tend to present to the doctor when they are in stage 3 and 4. In such cases, robotic surgery does not have any role. So we have to do something called as a traditional cytoreductive surgery. And apart from cytoreductive surgery, over the last few years, we have additional technologies which have come in. So I would like to ask Dr. Shabber Zaveri to elaborate more on this. According to the latest things which we do in our particular hospital, what are the things we can do for a patient who is presenting, say, with stage 3C ovarian cancer? What are the things we do?
So essentially, once it has been staged as a stage 3 ovarian cancer, we know that this disease has spread into other parts of the abdomen, not necessarily going into other parts of the body. And the conventional treatment for these patients used to be, either give them chemotherapy first, then do a surgery, what is called as a cytoreductive surgery, and then give them more chemotherapy after that. Or if the disease was operable, then you first did a surgery and then gave chemo. But what was seen is that most of these patients, after this line of treatment, which is a conventional line of treatment, these patients presented with recurrences of the disease within the abdomen. And that could happen as early as 6 months after the treatment was completed or later than that. So what happened was that there was a disease called as a pseudomyxoma peritoni, which generally originates from a burst appendix, and then the mucin spreads all within the abdomen, and there's a huge distension of the abdomen causing the intestines to get compressed and thereby leading the patient into weight loss, difficulty in eating, and being very sick. So to treat that disease, a procedure called HIPEC was done. So HIPEC stands for hyperthermic intraperitoneal chemotherapy, wherein after the surgical removal of the tumor, there is a specialized technology wherein we perfuse the abdominal cavity with a chemotherapeutic agent at a temperature of around 41 to 42 degrees centigrade over a period of time, which is generally about 90 minutes. They found that this particular technology was very, very effective in reducing the recurrences of the pseudomyxoma patients. So therefore, we adopted the same technology for ovarian cancer, knowing very well that these cancers will come back in the abdomen even after the treatment is completed. So hence, we started doing this particular technique way back in 2013-2014, wherein after removal of the ovaries, uterus, and whatever other organs had to be removed with the lymph nodes, when we would say that there was no macroscopic disease or no visible disease in the abdomen, then we used this particular procedure called HIPEC to reduce the chances of recurrence within the abdomen, and we found very positive results. So recently there was a randomized trial which was done in Netherlands, wherein it was proven that this technology worked very well for patients with ovarian cancer, and that it increases the chances of survival and decreases the chances of recurrence of ovarian cancers in these patients. And we've been doing this since almost a decade now, and we've found some very, very good results with that.
Dr. Suraj, are all the patients eligible for HIPEC surgery followed by HIPEC, or is there any selection criteria?
Selection criteria are both the disease factors and the patient factors. Firstly, because it has got its own side effects, the patient has to be chosen very carefully that they are fit enough to tolerate the procedure, their overall general condition, the age and all that. But with more and more experience, we are able to offer this to increasing number of patients. Secondly, even the disease criteria are important. It is only for certain stages. Very early cancers may not require. And again, very advanced cancers, if we have left behind gross disease, means if there is macroscopic, that means we can see big residual disease with the naked eye, even then the HIPEC is not going to help. So it is in a certain subset of patients who are advanced, who are fit enough, and then whose gross disease, that is macroscopic disease, has all been completely removed. In such patients, it is of the greatest benefit.
Dr. Hemanth, what if the patient is not fit enough to tolerate a HIPEC procedure? Or what if the patient is not even fit enough to undergo a cytoreductive surgery? What are the options available for locally advanced or even metastatic ovarian cancers, especially if they have a lot of ascites or if they have intestinal symptoms? What are the options we've got?
Ovarian cancer is notorious to present in later stages, and it generally presents in a stage where it is outside the ovaries but luckily confined within the abdomen, so it is still amenable to treatment if not cure per se. So most of our patients present to us with fluid in the abdomen, which is called as ascites. So this is a situation, and patients, because of that ascites, they are not able to eat too well. There is a significant amount of weight loss, which we would call as cancer cachexia. So this such situations we do not offer surgery for the ovarian cancer as soon as we see the patient. So with evidence, recent evidence, and also for quite some time now, so such patients can be treated with chemotherapy initially. So with this chemotherapy, we give them essentially 3 cycles, sometimes even more, based on how much the disease reduces. So with this chemotherapy, first of all, the ascites dries up and the disease inside the abdomen reduces. The patient's general condition improves. She's able to eat better. She puts on some weight, and she will be what we have noticed is that by about 3 cycles, there's a marked response in terms of the disease burden inside the abdomen, which we assess with CT scans and MRIs. So once this chemotherapy is being completed, either totally of 6 cycles or 3 cycles, in the middle, after 3 cycles, we again reassess with an imaging, If there is a significant amount of response, clinically we look for ascites, improvement in general condition, and radiologically, that's with CT scans and MRI, we assess whether the disease which was there initially has reduced significantly. If we are happy with the response after 3 cycles of chemotherapy, we offer what is known as cytoreduction, and during the process of cytoreduction, if you are able to remove all the macroscopic disease, that is disease visible to the eye, we would proceed to what we have been discussing, and that is hyperthermic intraperitoneal chemotherapy. So not all patients who come with carcinoma ovary are fit for this procedure in the initial part of their treatment. So we stagger it after giving a few cycles of chemotherapy, we reassess, and then we perform the cytoreduction followed by HIPEC if she is a suitable candidate for it.
So just to add to what Dr. Hemanth said, is that in patients who are unfit for major surgical procedures, so we have a technology called PIPAC which we would use. So if the patient is willing for that, we use this technology. It's called as pressurized intraperitoneal chemotherapy, wherein we use the laparoscope to visualize the interior of the abdomen and to quantify the amount of disease present in the abdomen, calculate what is known as a peritoneal carcinomatosis index, and then use chemotherapeutic drugs through a separate small port and inject it into the abdominal cavity at a high pressure. So that causes the chemotherapy to enter the abdomen like an aerosol and get deposited or coat the whole of the abdomen in a very uniform way. And this procedure is minimally invasive, and the chemotherapy what is used for doing this PIPAC procedure is 1/10 the dose of what would be used when we are doing systemic or intravenous chemotherapy. So thereby patients don't suffer from the side effects of systemic chemotherapy, and since the minimal access has been used, they are up and about the same evening and probably go home a day or two later. This particular use of PIPAC has basically benefited a lot of these patients who refuse systemic chemotherapy in patients who have recurrent accumulation of fluid in the abdomen, and for some reason these patients don't want to undergo further IV chemotherapy because of its side effects and complications. This is a very useful technology to be used in these patients, either whether they are ovarian cancers or whether they are cancers arising from the colon. So basically it is used to treat something called as a peritoneal surface malignancy, where the disease spreads from the organ of origin to the other parts of the abdomen on the peritoneal surfaces. So it's a very good technology to use, and patients really do very well with that.
As discussed by our esteemed panelists, ovarian cancer generally tends to present in stage 3C, wherein traditionally the expected life survival used to be somewhere around 18 to 24 months. But with the advent of these latest technologies, the key thing here is to perform a good cytoreductive surgery and have no gross visible disease. Then we do hyperthermic intraperitoneal chemotherapy, and following this, the results now are the overall survival is almost touching 5 years now, which traditionally wouldn't have been possible. Now, of course, there is the benefit of having good medical oncology coverage. Also, HIPEC plays a very good role in getting these kind of results. So, thank you very much for the discussion.
Thank you.
Yeah. Let's end the discussion here and